Ça va? Bonjour. So good morning, everyone. So today we will start with the session on acute respiratory infections. And it's my great pleasure to introduce the two chairs of this session. Dr. Firdousi Quadri, the head of the Musical Immunology and Vaccinology Unit at ECCDRB in Bangladesh. And she's also the founder and led the Institute for Developing Science and Health Initiative, IDESHI. And Professor Philip Van Ems, who is a medical doctor and is currently the head at the Epidemiology and Infection Control Department at Lyon University Hospitals. And he leads a research group on epidemiology of infectious disease, including vaccine projects in the International Center of Research in Infectiology. So now, Philippe and Firdousi, you can introduce the speakers of this session. Thanks.
Thank you. Thank you, Florence. Pleasure to co-chairing the session on acute respiratory infection. It's also a pleasure to introduce. Can you hear me? Thank you. And it's also a pleasure to introduce Valentina Picot, a short introduction. And she has been at the foundation from 2006, has been working on applied research and public health research in LMICs, including the Rohingya population in Bangladesh with us. And she's very brave. She goes to all the very difficult places in Asia and Africa. And she has held many positions at the foundation, and she is very knowledgeable on low acute respiratory infections. And her work is on regulatory affairs and monitoring and R&Ds. And so with that, I would like to invite Valentina to the talk. Thank you.
Thanks a lot, Chala, for this introduction, and Philippe, and everyone for allowing me to give this talk today. So obviously, I'm very happy to be part of the Vanerius Foundation and present the work that we have been doing in acute respiratory infections. I was named as the head of acute respiratory infection after working for many years in the in many different, for very different topics in infectious disease research. And so I'm going to give you just a very quick and simple, as simple as possible, the strategy on acute respiratory infections that we have put together. I have 20 minutes, as I understand, and so I start now. The session, I just want to bring a little bit of a snapshot on why this session, and we are going to have here just a quick introduction of the things that we are currently doing only on research, but this strategy also include other components that as you will see here. And I'm happy to have as sharing Philippe and Chala. I call her Chala, Firdausi Kadri, because they have been with us in the endeavors of all these studies. Philippe on many studies in the past on the acute respiratory infections, guiding a lot of the things that we try to do. Obviously no support for this time. And then Firdausi Kadri, whom I've been working for a long time now on many projects in the camp, Rohingya camp, and I couldn't make it more sense. And every person that is in this session are actively working at the forefront and the front line of the work, not far away from it, at the front line. Madranto is working at the front line of the work, Navid as well, Abu Dakar, with the people in the implementation of the projects. And I'm super happy just to see that they are all coming here today. At the same, obviously, as Daouda Koulabi from Cote d'Ivoire. So it's a pleasure. One little parenthesis before starting the strategy. RI is obviously an acute respiratory infections and is a thematic, but it's very difficult to think about thematics with the obliged interlinkages and logical interlinkages that are between the thematics that we're presenting here. So by default, the interlinkages with pneumonia, bacterial pneumonia, and RI, and IMR, or the evident interlinkages of COVID-19, who, when it's symptomatic, produces pneumonia, and there is a very, very strong linkages here. So that's what you will see presented here, COVID-19 projects on the RI umbrella. And that's why also we are trying to put those thematics together to synergize and to also to make sense of all the things that we're doing, somehow presenting here vertically, but actually they have an horizontal approach. So the mutualization of our synergies and capacities. Needless to say, we know what pneumonia is one of the biggest mortality in children under 5 years old. And it's killing is the highest mortality, particularly in low middle income countries. It's caused by bacteria and viruses, and it's oftentimes a combination of those pathogens, and can be prevented by immunization, by adequate nutrition, by addressing environmental factors, and also by when pneumonia is caused by bacteria, with antibiotics. But the misuse of antibiotics, the overlapping of this diagnosis is becoming more and more difficult to treat pneumonia correctly, even though we can do it. And it's a very complex disease. So 99% of deaths due to pneumonia in young children occur in developing countries. And this is a big problem, and particularly in certain countries around the globe. So we have about 20 countries that is particularly affected on pneumonia, and that's where we would like to focus our research. And in those countries where we see the pneumonia is extremely affecting more children around the globe. So what works in pneumonia? We obviously have this very high level research, which is very important, and we have to leave the groups with that expertise to do the job on that. But we want to make the job that we can do very pragmatically on trying to find questions or answers to things that are public health relevant for the people that are dealing with that. So how to achieve better behavior and care-seeking behavior, how to increase the breastfeeding through the work, how to use the vaccine, how to improve the introduction of vaccines, how to survey the circulation of PCV vaccine for the serotyping replacement, for example, how to use oxygen and other commodities in a better form, how to use the new clinical algorithms to guide better the clinical diagnosis of pneumonia. WASH interventions that are potentially and obviously linked to that, and obviously improvement of environmental factors like how to improve the use of carbon stoves or not in there. Obviously we cannot address every single of these things, but we can actually through our projects with a one single hypothesis try to understand also the demographical factors that make these other holistical aspects of pneumonia more we can answer it better. on a public health approach. We are not here to be, I mean, at least from the side Fundación Mero, we are not big scientists to answer big questions, just very particular ones that can help people around. And so I don't want to go a lot in the details, but our agenda is very simple. We want to establish an approach that is integrated within our capacities, because we have these capacities, to help reduce severe pneumonia cases, particularly in children, by addressing predominantly contextual public health setting questions and foster practical improvements. Something simple that we can help around. Our population is children under 5, because this is where the mortality is highest in these countries where we want to intervene. And obviously the countries that I just mentioned, and and refugee camps and crisis populations. So what is our plan? Is basically, I am going to show you research today, which is here, but we are going to show you also that research alone cannot do much when you have so many lacking aspects in the country. So what about structuring and reinforcing capacities? We cannot address all of them, but we will try to address those that we can address. And what about fostering awareness and advocacy? Because if we don't create momentum, nothing will happen, but only the publications that one can have on their own studies and things. But what about joining networks and trying to create momentum of what we do? We will do it at our scale level, because we can do as much as we can do with our capacities, but we will try to foster on that. So gauging our work, what we have done so far and Fundación Mero with pneumonia. And pneumonia started in 2010 with the first multicentric study that was launched. And forgive me for people that have seen this already, but some people have not, and a strategy cannot change from one other to the other. So that's that. It started with a pneumonia study that we launched in 9 sites. And then I'm not going to read the different studies, but this is the different studies that we have launched. We launched this study. I'm very happy to have also here with us Glaucia Bacala, with whom we launched the pneumonia study in 2010. And this actually launched many of the different projects on acute respiratory infections that you can read through the years there. And that has allowed us to create momentum on the different aspects of pneumonia. Then we were having these different kind of plans. And then suddenly COVID came in and said, okay, listen, we have to do something about COVID. And Philippe talked to us, and we launched the non-support study that you will see more about later on. And then we launched other projects on COVID, forcibly displaced population, COVID-19 studies, to understand a little bit better about the circulation of the virus, and also serological responses in these specific settings where even diagnostics is very, very difficult to have. And so this pipeline keeps moving as we are able to put it together, and as we are able to make things happen. So these are the 3 projects that you will hear later on as well. And so now the thought for 2022, obviously the projects that you see happening here, they are not stopping. So we still have to carry with this, the load of the piloting that we are carrying now. There are many reports and white books and publications that will allow to create advocacy for pneumonia that we're still in the pipeline, and we have to carry on that. So what is previously is not stopping for many of them, but we are going to launch a second multicentric Take 2, what we call the Take 2 pneumonia study. We try to answer also practical questions on how to use oximeters, how the CDS algorithms, which is the clinical decision support algorithm, can make a difference at the front line of very primary healthcare units. And so there are different studies on the pipeline that we will launch on next year, particularly on those countries where we are finding the more difficulties. Here, just to show quickly where the non-support study is working. This is when explained later on, and the forcibly displaced population project. We are saying that we work particularly on low middle income countries and crisis settings. And I just want to show that where our sites geographical spread is. So everything that we do is aimed in Africa, particularly in Asia, but also we have some sites in Latin America, and then the Middle East. So engaging what we do and trying to see what protects, prevent, and treats on pneumonia, we're saying, okay, so far, what have we done? And what is this is impacting or not, in a very nutshell. So we have bring evidence on pneumonia etiology on a number of countries that there was no etiology findings in the past. And this was also in tandem with a big study that's called PERCH that you likely all know about it. And then we complemented with other sites that they didn't have. The only site that overlapped at the time was Mali. Then assess host biomarkers for the pneumonia diagnostics, understand how CRPs might be able to guide better diagnostics at the front line of the process, or maybe introducing at a point of care like a BINAS. So trying to understand how to improve the diagnostics at that level where radios are not available and things of that sort. Facilitate PCV vaccine introduction. It will build evidence for improved case management of critical settings. This is just a global snapshot of what we think of. This is a log I keep on what each of the projects from one to one time, and then what will be the potential public health impact and research capacity strengthening impact that these projects have put together and built together. So for example, if we take any project, we want to see, okay, how many people were trained on clinical research management? When you going to launch a project, you go into a site and you realize that sometimes people know how to do routine, but they have no idea how to establish a methodology for clinical research and or research in principle. So the adherence of the methodologies, the writing of the SOPs, the understanding how you include, how you do these things, it builds capacity on the side. So even any time we want to launch a new project, and also for their purposes, it will be interesting to have also at the lab level, many different techniques and technology transfers were done through these projects for the projects for the countries to have these capacities to be able to test in a given situation. And I just have an anecdote quickly from in the Rohingya camp. We trained so many staff, nurses and field staff on clinical, on the particularities of methodology. After we finished the first project, many of these people were demanded by numerous agencies, and Chala is aware of that, because they have these capacities which they didn't have before. So that means that they are also positioned themselves career-wise better because they have learned things that we can transfer to them humbly, because we are not here to claim huge things, but simple things. So again, publications are not our driver because we are not doing this for publications, but publications are extremely important because they create advocacy and allow people to sell this information and to be able to do better advocacy. So we have, thanks to the different projects that we carry in different places, we have publications that have come out on many different things. This is the latest ones on Nosocour. This came out about 2 days ago or something like that, on a publication that we put together with many different groups that are working on pneumonia. And so it's nice to see what is pulling off from the different studies. And many of you that are here present, Graciela, are all here and are present and part of these publications. And these are the two that are on the pipeline and on the way. So just wrapping up what we have done, gauging our work. So we have carried about multiple studies around the globe, pursuing pneumonia questions and understanding. We have established capacity numerosize several now members of the Gabriel Network. We have established biobanks with characterized, regulatory, ethically consented, that have enabled additional branch studies. We have mostly worked, the outcome of our work is to provide, to a given extent, again, data and guidance for good public health value for the pneumonia cause. And then obviously the publications that I just mentioned. So here, just a few pictures of the work on the field, and I will show you very quickly after a little video that I have made actually for other purposes, but I think it will be nice to see that. I have very few minutes. So just very quickly, we go back to our house with the 3 components. So currently, in terms of research collaborations, this is the list we're carrying. In terms of structuring and reinforcing capacities, as you see, we have different courses that are addressing the pneumonia arena, not only pneumonia, but also addressing AMR and addressing other aspects that are interlinked to pneumonia and the vaccinology. And so these are happening now. This is something that we are carrying now in the pipeline, in a different pipeline that is not research, that we call it public health initiatives. We foster awareness because we have the pneumonia, we participate in the Pneumonia World Day. We partner with networks to facilitate, this interlinking with networks. And when we have data, we facilitate data to governments through that, and as well, obviously, the publication. So the part awareness, cool, new. So we're, again, launching this multicentric study, these other studies that I just mentioned before. We are going to launch a clinical research management course that is in link with the TDR for next year. And we are also going to have trainings that are going to be tailored for more implementation at the field level for care-seeking behavior. And then we are going to, I will be talking, because I think, again, the capacities that will build on NGS on bioinformatics are cross-border, cross-sectorial. So the thought of having this course on NGS and bioinformatics that we have discussed with Emily and Florence, with a large audience, evidently. And then we have, for foster an awareness, that doesn't mean that the pneumonia world there will happen again. We will continue the previous current aspects, but we are going to also launch next year a global pneumonia forum with all the stakeholders that are leading on this agenda to generate useful for public health impact. And then I'm not going to talk about this, but these are indicators that are allowing us to say, okay, when you go to a population, what do you want to know before? Indicators of performance. And I think I repeat this one twice, so forgive me. I just to say that when we try to put together the pneumonia, we try to remember the prevent, protect, and treat. And we try to remember those indicators so they guide us also where we want to go. And so here, just to show you the different things that we are doing that interlink with our pneumonia agenda and other thematics as well. And this is a declaration. Graciela was there when a declaration was signed by a number of stakeholders during the last pneumonia forum that was held in 2019, early in 2019. And then here is just an acknowledgement of all of you that have been so supportive in making this strategy happen. So thank you very much. I'm going to show you just quickly, but super quickly, and I think I have 2 minutes, a little video that should be here. I don't know if it's going to show. Sorry, thanks. I don't remember how you do that. Merci beaucoup. Merci beaucoup. Okay, just a quick video, because it's easy to talk when you are here, but it's good to have a contextual feeling of what is the work on the ground, right? So here is the team. We have also very nice work done in Congo as well now, but so this is the camp, the Rohingya camp, and the teams. I'm not going to stay all the time in this video, but just to give you a little bit of a feeling of what means, you know, all the paperwork, all the methodology that you have to implement to ensure that everything is aligned, the working stations, the algorithms, is humongous work when you have to implement like that. Every single paper, every CRF, every informed consent, everything has to have a very delicate follow-up. And that's just to put that together is huge. So just so that you get a little bit of a feeling of that work on the ground. You know, the chronometers, everything that has to have a very careful follow-up. The follow-up visits is because this study had follow-up visits and this and that. So I'm not going, and also the treatment, because we are not leaving just a diagnostics. We support the child with the reference, with the follow-up, with the treatment that they require for those purposes. So that's it. Thank you very much.
Thank you, Valentina. We can have only one short question, and then overall, when we finish the session, we'll have question answers. Anyone with a quick question for Valentina?
Yes. Thank you very much, Valentina, for this roadmap. I would like to thank you to together initiate this pneumonia program and see the evolution of this beautiful work that you are doing. And I am very happy to announce that we will work together in meningitis and pneumonia projects in Africa. And also to thank you so much, Philippe Van Ems and his team that help us very much for the analysis of this work.
Absolutely.
Thank you. Just a comment.
Thank you. And we look forward to working in Bangladesh more. Thank you.
Thank you. Thank you very much, Valentina. So I will ask to Mitra Elahi to present the result, the first result of Nosocore multi-center study on nosocomial transmission of SARS-CoV-2 virus, and the first result in France. Mitra is a senior epidemiologist. She graduated in Lyon University, and she obtained this PhD regarding epidemiological study on cancer. Now she added to his curriculum epidemiological project on infectious disease, but also with a huge project with companies such the project of Dingdi in Malaysia. Then Mitra, you have a 20 minutes presentation and one short question after.
Yeah. Good morning, and thank you very much for the organizer to give me the opportunity to present some results of our project called Nosocore. Nosocore is a collaborative study between Lyon University Hospitals and Mario Foundation that has been funded by several organizations that are listed here. Here you can see the outline of my presentation. I will provide you some the objective of the project, and then give you some results about the data we have collected in French hospitals. Okay, participating country in this prospective multi-center observational study were 13 French hospitals and 7 international countries that were coordinated by Valentina Pico at Foundation Mario. I don't know why I didn't put. The main objective was to describe clinical characteristics of community and hospital-acquired SARS-CoV-2 infection. Our secondary objective were to estimate the prevalence and incidence of nosocomial SARS-CoV-2 infection and estimate also mortality rate according to clinical features at admission, and this stratified by age, presence of comorbidities, and of course, community versus hospital-acquired infection. Any adult patient or healthcare provider that presented with syndrome of COVID-19 patient was eligible to participate. Confirmed cases were patients with a positive RT-PCR test done in nasopharyngeal swab. We collected data from, at least in France, we collected all data from electronic medical records using an electronic CRF that was designed for the purpose of the study because it was impossible to have a face-to-face meeting with the patients during the pandemic. We monitored all clinical outcome up to hospital discharge or in-hospital death. And also we surveyed all hospital wards for the identification of secondary cases. All my presentation will be based on data from French hospitals because I guess the next presentation will be on data collected from the international sites. So in total, we included 1,380 patients and 782 healthcare providers during the first wave of the pandemic from February to June 2020. Data on healthcare providers are currently under analysis. So what you are going to see is concern only patients. So here you can see the baseline characteristic of patients. The median age was 70 years, and we had almost the same ratio of men and women. Almost 80% of patients were hospitalized in medical wards, while 60% were admitted to ICU directly. And we had 5% of patients that required subsequent transfer to ICU. The median duration of hospitalization was 7.5 days, and the overall in-hospital mortality rate was 20%. And as you can see at the bottom of the table, the mortality rate, the highest mortality rate was observed in the oldest age category. As you can see here, the large majority of patients had at least one comorbidity, and cardiovascular disease was the most common one. The general symptoms were, the most frequently reported symptoms were, as we can see normally in other patients, fever, general weakness, and cough. In accordance with the main objective of Nosocor, our first study was aimed as to see the characteristic and outcome of hospital-acquired versus community-acquired COVID-19 patients. The results of this study are under revision by the journal Infection. We classified all patients according to the ECD definition of nosocomial COVID-19 infection. As you can see in this graph, the majority of cases were community-acquired infection. We could define 70 patients as undetermined because their symptom appeared 3 to 7 days after hospital admission. 42 were probable cases because symptoms occurred 8 to 14 days after admission. And finally, we had 232 confirmed cases because symptoms appeared 2 weeks after hospital admission. Oh, sorry. Okay. So hospital-acquired patients were significantly older and had more underlying disease such as cardiovascular disease and cancer. However, we did not see a significantly higher risk of death between confirmed hospital-acquired and community-acquired patients. Here you see the results of the survival analysis, and again you can see that there is no statistically significant difference in the median time to mortality between hospital-acquired and community-acquired patients. This graph shows you the distribution of COVID-19 patients, hospital-acquired and community-acquired over the time, and according to the date of symptom onset. As you can see, we can see an accelerated decrease of the number of hospital-acquired patients during the period of the study from February to June, showing that there is a continuous improvement of control measure during hospital stay that lead to reduce the number of hospital-acquired infection during the study period. From now, I'm going to present you some studies, but the data are only for patients that have been admitted to Lyon Hospital. And the first one was aimed as investigating factor associated with admission to intensive care units. So in total, we included 412 COVID-19 confirmed patients with known date of hospital discharge or death. The median age was 72 years, and 60% were admitted to ICU. 77 were hospitalized in medical wards, of whom 8% required subsequent transfer to ICU. Again, 2/3 had comorbidities. Cardiovascular disease, diabetes, and chronic lung disease were the most commonly reported. The most reported symptoms were as usual for COVID-19 patients. The time between onset of symptom and hospital admission was significantly higher in patients hospitalized in ICU as compared to those hospitalized in medical ward. And the overall fatality rate was 21%. And as you can see, it was almost 3 times higher in patients hospitalized in ICU. This graph shows you that there is a correlation between symptom onset and hospital admission and age. Older age being associated with a shorter delay between symptom onset and hospital admission. And due to this very strong correlation, we couldn't detect the independent effect of each of these variables. So to determine factor associated with ICU admission, we used 2 models. When age was put in the model, older people had less risk to be hospitalized in ICU, while temperature and oxygen saturation, oxygen saturation less than 90% were associated with a higher risk of admission in ICU. When age was replaced by delay between onset of symptom and hospital admission, as you can see here, monocytopenia remained a risk factor, and CRP was not anymore associated with the risk of hospital of ICU admission. So we can see from this study that age and delay between symptom onset and hospital admission were associated with the risk of ICU hospitalization. Age being a fixed variable, intervention which shortened this delay could improve the prognosis of COVID-19 patients. The second study, which is I'm not going to present, is under revision by PLOS One for the moment. The objective of this second study was to describe characteristic and symptom of COVID-19 patient, community-acquired COVID-19 patients at hospital admission according to the delay between symptom onset and hospital admission, and to identify determinant associated with the delay of admission. We included in total 827 patients with non-delay between one set of symptom and hospital admission. And we classified them into 2 groups. The short delay group included patients that for whom a symptom occurred 7 days before hospital admission. And the long delay group included patients for whom occurrence of symptom was more than 6 days before hospital admission. You can see here the characteristics as baseline, which are not very different from the first study we did. The delay between symptom onset and admission was significantly higher in significantly higher in those hospitalized in ICU. And compared to patients with short delay, those with longer delay were younger, reported more frequently reported symptom of COVID-19, had higher BMI, higher CRP level. However, the mortality, the fatality rate was significantly lower in this group of long delay compared to those who came to the hospital more quickly. So then we wanted to see what is the association between patient characteristic and the delay between symptom onset and hospital admission. In red, you can see variables that were associated with shorter delay between onset of symptom and hospital admission, age, presence of comorbidity like malignancy. And in green, these are variables that were associated with higher delay between symptom onset and hospital admission. And when we adjusted the, in multivariate analysis, only age and CRP remained significant, age being associated with a lower delay between symptom onset at hospital admission, while CRP was the correlation was in the other way. The conclusion from these studies are rather questions to be answered maybe in the future studies. We had a lower number of older adults in ICU. Is because declining immune system is older adult is compensated by more prudent behavior, so they avoid risk, and so this lead to early hospital presentation? Is that widespread information communicated by social media on the low COVID-19 morbidity and mortality in young that could delay access to care in this population? This lower number of adults in ICU is a consequence of rapid management thanks to earlier presentation at hospital and or shortage of intensive care resources in the context of pandemic. And why higher mortality rate in older adults? Probably because of the presence of much more comorbidity like cardiovascular disease and cancer. The third study was about tobacco smoking and severity of COVID-19. So the objective was to investigate the impact of smoking habits on the severity of clinical presentation at admission and prognosis of laboratory confirmed COVID-19 patients. We included more than 600 patients with documented information on smoking habits. You can see here we had 3 groups: 62% never smokers, 1/3 ex-smokers, and 5% active smokers. Ex-smokers were older than active or non-smokers, and the most common comorbidity in all 3 groups were the same: cardiovascular disease and diabetes. But we had significantly higher rate of chronic lung disease in active as compared to never smokers. And hospitalization in ICU and mortality were significantly higher in ex-smokers as compared to current or non-smokers. We tried to see what are the variables that are independently associated with severe outcome according to the smoking status. As you can see, ex-smokers were at higher risk of severity, while we could see a decreasing trend of severity in a smoker as compared to non-smokers. You can see also other factors like dyspnea, temperature, and high CRP level and monocytopenia that were associated with the severity of COVID-19. So this paper showed that the observed difference of outcome between active and ex-smokers confirmed the relevance of distinguishing these 2 populations when investigating the impact of smoking on the severity of COVID-19, because we saw a lot of papers that have been published on the role of tobacco smoking on COVID, and normally they have only 2 groups, smokers versus non-smokers, and it's very important to have the ex-smokers also. Of course, misclassification bias could occur in our study. Worse health seeking behavior in smokers, misreporting of patients because of fear of stigmatization could also explain the observed lack of association between current smoking and adverse outcome. Finally, it is very important to highlight that any evidence of a potential protective impact of smoking should be interpreted cautiously, as it could counterbalance the well-known deleterious effect of smoking on health. I'm just going to finish by providing you some quick information on another project we conducted, which is called Immunonosocore. The principal objective was to describe the serological response in people infected with SARS-CoV-2 infection several months after the infectious episode. So we invited 200 patients from Lyon Hospital that had participated in Nosocomial project. 2 visits were scheduled at 6 and 12 months after the first COVID-19 episode hospitalization. We collected blood sample in order to measure SARS-CoV-2 antibodies, and we also built a biobank for future immunological studies. We also administered a short questionnaire in order to obtain some information about persistent COVID-19 symptoms, vaccination of COVID, influenza, and other probable hospitalization between these 3 times. The results are currently under analysis. So to finish, I would like to thank all French PIs, Consortium of COVID in Hospice Civil de Lyon, Department of Database of, Lyon Hospitals, Clinical Research Associate, of course, the laboratory of Professor Lina, and Foundation Merio, of course. And I would like also to thank a lot, of course, Professor Van Eps, who convinced this study. I think thanks to his very great vision, because he came to me and he told me we need to write a protocol on nosocomial transmission of COVID-19 just after the first case of confirmed community-acquired COVID-19 in France. So we started very, very quickly to write, and we had everything ready once we had the first nosocomial cases in France. Thank you so much.
Thank you, Mitra. And we have time for one short question after the next. Yes.
Yes, I didn't get the hypothesis that you have that should be a difference in people getting in the community COVID infection and in the hospital COVID infection. What was the hypothesis that there must be a difference in COVID infection?
What was the
hypothesis that you have that there must be a difference in COVID infections, people acquiring infection in the hospital and people coming from outside from the community?
What do you mean by differeces?
The hypothesis. What did you wanted to see?
No, I mean, the objective was to see the rate of nosocomial transmission. So, because of like all respiratory viruses, we could imagine that there will be nosocomial transmission.
Of course, but we had many medical and nurse infections, not only in the hospitals. Most of them came from the community and came to the hospital, and also they did the transmission. So it's not, it has many variables inside of the hospital, the problem of COVID transmission. And I didn't understood very well which was the difference that you wanted to find between in the infected people.
Okay.
I'm sorry. Yes.
No, that's okay. I mean, we went from the hypothesis that maybe the characteristic could be different at baseline.
Yes,
I don't know if you want.
We can take this question for the general discussion, just because the patient were hospitalized for severe disease, and if they acquired SARS-CoV during the hospitalization, we can see that maybe we can expect that because of the underlying disease and the reason of hospitalization, that could be a severe disease, could worst the prognosis. And maybe we have not all the data analyzed, but it was not the case. So this is just delay during time when death occurs, but the rates after the diagnosis of COVID was not higher for between the two groups. But we are very prudent with this conclusion. So maybe we can go to the other one and keep your question for your general discussion.
Thank you. So the next talk is by on the nosocomial multicenter study and it's going to be presented from the international sites by Mandranto from Madagascar, who is at the Charles Marie Laboratories, a scientist there, who has climbed up the way and is now is a scientist working on the nosocorin from Madagascar. Thank you.
Thank you, Chair, and good morning, ladies and gentlemen. First of all, I would like to thank the organizers for inviting me today. And my talk, my presentation is a talk about the nosocorin study in Madagascar. I will divide my presentation in two parts. At the first time, I will share you the diagnosis of SARS-CoV-2 in the LRM lab of the CSM. Then I move to the nosocorin study implementation in Madagascar. As I presented yesterday, we received and treated samples. And treated over 13,000 of samples during the period of April 2022 up to October 2021. We have a positive rate of SARS-CoV-2 of over 29%. In these figures, we have the evolution of the SARS-CoV-2 detections that we have recorded in the CICM. This evolution is comprised of two waves. In April up to November 2020, we have detected over 27% of cases. And the second wave was between January up to October 2021, in which we have detected 32% of positive cases. Samples treated in the CICM comes mostly from the hospital university. It is not described here, from the hospital universities of the city in Madagascar. Here we can see the different hospitals which sent us the samples. We have mainly the hospitals of Pefelatanan, followed by Andutapenak and Anusial, localized in the city of Antananarivo. The age group distribution. In the age group distribution, we have a median age of 37 years old, with almost equal number of female, with almost a number of female cases compared to male cases. It was also said yesterday that symptomatic cases are more frequent compared to asymptomatic. So in this table, we have details of number of samples tested in the laboratory. We can see here that from the hospitals, we have a high number of symptomatic cases. And also with the CTC2, with 87% of symptomatic cases. CTC2 is a center for the treatment of COVID-19 that have been created by the authority to fight against the pandemic of COVID-19. Now, let's move to the nosocorin study implementation in Madagascar. We know well that medical staff and patients are exposed in at a high risk of SARS-CoV-2 nosocomial transmission, and the main factors contributing to an increased risk of SARS-CoV-2 infection in hospitals include the type and duration of exposure, the increased community transmission in areas where health facilities are located, the presence and severity of symptoms, the poor use and inadequate supplies of PPE. For information, in Madagascar, there is two studies in progress about the COVID-19 transmission. We have the household transmission of COVID-19 conducted by the Institut Pasteur of Madagascar. And the second one is the study on the multi-center study on nosocomial transmission with the Fondation Mérieux. So the objective of nosocomial study is to describe and document suspected or confirmed cases of nosocomial SARS-CoV-2 infection, the clinical spectrum and the determinants at participating hospitals. The secondary objectives are to describe and document cases of community SARS-CoV-2 infection, to describe and document hospital-acquired SARS-CoV-2 infections, and to describe the infection control practices implemented during the occurrence of hospital cases of SARS-CoV-2 and investigate the associations with the attack rates of nosocomial SARS-CoV-2 infection. The NOSOCAR study is a prospective non-interventional study, which is implemented in the three main hospitals in the Antananarivo, the University Hospital Lafanusial, and Utapenak, and Bifelatanan. We expect to receive 250 suspected cases per hospital. We have already obtained the approval from the Committee Ethic in the Ministry of Health. About the eligibility criteria, participants are patients and healthcare professionals within the three participant hospitals. It could be adult child patients or HCP from the hospitals who present an infectious syndrome based on the WHO definition. About the work plan, patients and healthcare practitioners are invited to participate in the study, and they are included in the study, and the CRFs are completed. Specimen collection have been performed, and for the RT-PCR detection of SARS-CoV-2. Then we integrate all the results in the CRFs for the results, and also we send the results to the authority. About the expected outcome, all data and informations collected and recorded in the CRFs will provide an additional argument for strengthening prevention campaigns. It could pave the way for new recommendations on prevention measures. It could contribute to the improved control of certain epidemics linked to the respiratory viruses. About the progress of the study, now we have finished the recording of the CRF data. We have finished also the recruitment, and now we are the analysis of the data is now in progress. In conclusion, we can conclude that this NOSOCOR study allows the strengthening collaboration with clinicians on site, the collection of socio-demographic, clinical and exposure information of the participant through CRFs. And as said before, the data curation and analysis are now in progress. In parallel of this NOSOCOR study, we have also the sub-study called the NOSOCOR, immuno-NOSOCOR, which the main objective is to define the seroprevalence rate among health personnel who have been exposed to COVID-19 in the three hospitals. The study design have already described previously. But now I would like to show the progress of this study. So we have now already performed the collect of samples and from the 3 hospitals, and we plan to do the serological test with the VITAS instrument. The little problem for us is now the training for the installation and the use of this machine. I hope that it could be resolved soon. Before I end my presentation, I would like to thank the teams in the CICM, Professor Samson, Tiav, Phil, Rachel and Valentina from Fondation Mirieux, and the teams, the staff, medical staff from the 3 university hospitals. Thank you for your attention.
We have time for one short question after this presentation. No questions? Okay, thank you very much. We move to the next presentation of the Dr. Daouda Koulibaly from Ivory Coast, and will expose the preliminary result of Nosocore in Côte d'Ivoire. We have 10 minutes.
D'accord. Mais je diffuse comment? Non, c'est bon, c'est bon. C'est bon. Ok, merci. Okay, thank you. Merci. I'm happy to participate in this meeting. I would like to thank the organizer who invited me. I would also like to apologize for my English, which is very bad. So please note that some of your questions will be answered in French. Okay. As mentioned by the previous speakers, Nosocore study is a multi-study on nosocomial transmission of SARS-CoV-2 virus. And it's the same participating international centers. We have Bangladesh, Côte d'Ivoire, my country, Mali, Guinea, Madagascar, Brazil, and France. It's the same objective, to describe and document suspected or confirmed cases. Nosocore study is prospective, observational hospital-based study in adults and children. It's the same selection criteria, and it's the same expected impact as mentioned by the previous speaker. So let's move. I will give you a brief report on the situation of the COVID-19 in Côte d'Ivoire. We have recorded over 61,000 confirmed cases, around 700 deaths, 82% of district reported at last 1 cases, and over 1 million samples have been analyzed, and the average positivity rate is 5.6. Over 3 million people are vaccinated, and 900,000 are fully vaccinated. This is the epidemic curve of the evolution of cases and deaths. We observe the 3 epidemic waves. The third wave was short, but more deadly. This is the map of the distribution of COVID-19 cases and death. And we note that 95% of cases are in the Abidjan, the capital, economic capital. Okay. This is the distribution of COVID-19 cases among healthcare workers in Côte d'Ivoire. We note that the highest number of COVID-19 cases has been observed among doctors, caregivers, and nurses. This is the evolution of COVID-19 cases according to response measure in Côte d'Ivoire. And during the first wave, the Oxford Stringency Index was very high. The measure taken had made it possible to control the epidemic. For the 2 successive waves, the Oxford Index remained below 50. Now I will talk about the progress of the study in Côte d'Ivoire. It will seem like Madagascar and France. After the approval of the ethics committees, we selected 5 sites. We have 2 center university hospital, 1 private clinic, and 2 health facilities. Site training on the protocol took place from May 25 to June 5, and patients were enrolled from June 4 to March. It's the same algorithm as mentioned by the colleague from Madagascar. Screening is based on suspected cases according to the protocol selection criteria. After consent and inclusion, a nasopharyngeal sample is collected for laboratory diagnostic by RT-PCR. We have 2 CRF, patient and healthcare providers. The results are recorded and integrated in the CRF to research purpose. The preliminary result for Côte d'Ivoire, in the table 1, we observe the characteristic of the people recruited. We recruit 256 people, including 228 patients and 28 healthcare providers. A total of 145 cases were positive, and the attack rate was 8 per 1,000 healthcare providers. More than half of the cases were recorded in the hospital university center from Cocody and Angre, and 9 to 5% of cases were over 30 years old, and 57% of cases were male. Among the 145 positive cases, 92% are patients and 8% are healthcare providers. 11 people were hospitalized, including 1 healthcare provider, and 9 patients died. The time between the onset of symptoms and confirmation of COVID-19 was greater than 7 days for 63% of cases. In all 5 sites, there were infection prevention and control measures. COVID-19 has affected doctors, nurses, and midwives as well. Several health professionals have been affected. That show the table 4, which talk about the profit of healthcare workers recruited as suspected case. I would like to make a comment before closing my presentation. The risk of nosocomial transmission was high, considering the following factors: high prevalence of disease on admission, 57%. The healthcare providers were rich. The attack rate is 8 per 1,000 healthcare providers. And time taken for detection of COVID-19 is long. For 63% of patients, this time is greater than 7 days. And there were also mitigating factors for the risk of nosocomial transmission, like the implementation of infection prevention control measures in hospitals and containment of positive COVID-19 healthcare providers. I would like to thank all the people who contributed to the realization of this study. Côte d'Ivoire were very happy to participate in this study. She's willing to participate in any study that aims to improve public health. Thank you for your attention.
Thank you very much. One short question for the general discussion. Yes, José?
Yes, thank you. Just a quick question, not specific to Nosocore, but it was related to the discussion that we were having yesterday. You presented that 95% of the cases are in Abidjan. So my question is it about the availability of diagnosis in Côte d'Ivoire, or it's linked to the discussion we started yesterday about the capital and rural areas and COVID?
I can speak in French?
Oui.
OK, d'accord. Je pense que le taux de détection est faible. Il y a un article qui est passé récemment, il y a moins d'une semaine, de l'OMS qui indique que le taux de détection dans la région africaine est de 1/7. C'est-à-dire que si vous voulez avoir le nombre réel, il faudra le multiplier par 7. Donc, certainement que, compte tenu des stratégies de dépistage et de détection, donc à l'intérieur du pays, certainement que vous avez eu beaucoup de cas qui sont passés inaperçus. Thank you.
Yes. Part of the answer, it might be the fact that it seemed that only one among 7 of the cases are being detected more generally in the African continent based on an article that has been published recently. Thank you.
It's only one question, no time, Valentina. Yeah. Okay.
I just wanted to say that evidently we have 2,600 cases being recruited in Nosocore International. And the data here presented is fairly descriptive because with Rachel, luckily Rachel got here about a month ago, and we are starting to do all the data curation, and we have thousands of queries that we need to clean up, and then we will proceed to the data analysis that was somewhat presented by Mitra afterwards. So that's just to give that kind of consolidated from the 2 presentations given here.
Thanks. Thank you very much, Raza. Yeah. So the next presentation is by Abubakar Siddiq from Bangladesh, and he's going to present on one of the nosocomial studies in Bangladesh. Yeah. Yeah. It's on the low acute respiratory infections, etiology research in the Rohingya population and the use of point of care diagnostics in Bangladesh.
Perhaps as the next presentation are on other topic, perhaps it's better to have the coffee break now and to come back in at which time? In 20, yes, around 20 minutes, if you're all agree. In 20 minutes. Okay, thank you.
Please take your seat.
Start with Abu Bakr.
Yes, then this Abu Bakr Siddiq. Yeah.
Welcome back.
No more than 20. Yeah, yeah.
So, welcome back, everyone. We will start the presentations again, and after the break, we have Abu Bakr Siddiq from Aideshi in Bangladesh presenting on low acute respiratory infection among the refugees in Cox's Bazar, whom we call the FDMNs. So, thank you, Abu Bakr.
Thank you, everyone. Such an opportunity for me, and I would like to thank Meru Foundation, Gabriel Network, and especially Dr. Valentina for giving me the chance to present our study work in such a wonderful platform. Our study work titled as Lower Acute Respiratory Infection Etiology Research with Randomized Control Trial Comparing Case Management and Clinical Outcome with Point of Care Testing among the FDMN, forcibly displaced Myanmar nationals, also known as the Rohingya refugee in Bangladesh. In the worldwide, lower acute respiratory infection, particularly pneumonia, accounts for 15% of all deaths under age 5, which is most prevalent in South Asia and Sub-Saharan Africa, where 13 countries in this region accounts for 84% of child deaths. And pneumonia is the single largest death cause under the young children, which is much higher combined than the mortality rate of HIV, AIDS, tuberculosis, and malaria. So it is a major concern. So I would like to say something about the FDMN population. The FDMN, our government like to call them as FDMN, not Rohingya refugees. They started come to Bangladesh in 1970, and gradually their number increases, and ultimately in 2021, according to a UNHCR report, there are around 1 million FDMNs residing in Bangladesh. So this is a huge number. Their demographic location, the Rakhine state they are residing, which is very close to Bangladesh and the Chittagong division. So whenever any operation occur, they come to the Chittagong division in Cox's Bazar district. So the disease burden among the FDMN population, a study done by Director General Health Service Bangladesh in 2017. So here we can say that the acute respiratory infection accounts for 42% of the total cases, which is a huge number. Also, a very recent study, which is done in between 2018 and 19, we can see that acute respiratory infection accounts for the highest total number, 16%, which is highest in the young children, like 44% and 48% respectively in male and female. Also for pneumonia, it is higher in the young children, like 7% and 5%. So we worked on the 5 study sites, which is situated in the Ukhia Upazila of Cox's Bazar. I would like to show some pictures of our study sites. This and this one. So the selection criteria was the subject aged over 3 months, consulting at the healthcare unit, presenting with the larger symptoms like cough or dyspnea within the last 10 days, history of fever, which is measured axillary, and lower chest wall injury or any kind of symptom according to WHO criteria under 5 years. Also the exclusion criteria like asthma at exclusion or any bronchodilator therapy used, 1 month exclusion after the discharge from the hospitals or healthcare unit, or previously prescribed asthma, received any intravenous antibiotic therapy, etc. The demography, like we enrolled 538 cases and 516 cases, control groups, where the under 5 years is 282 and 259 in cases and control, and the over years group are 256 and 257 accordingly. So our whole study was designed to target 2 points: case control etiological research study, where the cases and control groups are enrolled according to the age matching. After obtaining the informed consent and filling up the CRF, we collected the sample at day 1. And in the nested randomized control study, we divided the case group into two groups, interventional arm and non-interventional arm, where in the non-interventional arm, we did the POC diagnostics, and the other arms are for routine case management. And then we follow ups in several day points, like 3 days, 7 days, and after 1 month. So for case control, etiology research, we collected samples from cases, different samples like urine, serum, whole blood samples, and the NPS, nasopharyngeal and NPS samples, where we did for whole blood and NPS samples, we did both the culture and antimicrobial sensitivity testing, also the RT-PCR to detect major potential bacteria for ARI like Streptococcus pneumoniae, Streptococcus aureus, and Haemophilus influenza type B. But in terms of control, we didn't collect any blood samples. And also I'd like to say that antibiotic activity, PCT and WBC data are on curation, and it is on processing. So that's it. For the point of care test management, we collected the samples from the interventional group like urine, and we tested Binax to detect the S pneumoniae C. polysaccharide antigen, and from the blood we detect the C-reactive protein value. And unfortunately, the BioFire multiplex array was not available in that time, and very recently we completed the viral testing using the specific primer probe by RT-PCR. So I already said that before, in cases 538, control 516, and these types of samples are collected. Our study was started in June 2018 and ended up in March 2020 during the outbreak of this pandemic. And here we can see that slightly the sample collection was higher in between September and December. So this is the lab methods. For Lari cases, we collected nasopharyngeal swab samples, both in the universal transport medium and STG media for the RT-PCR to detect this type 3 major potential bacteria. And from the blood culture, we also did the automated bacterial process to culture and identify the isolate the organisms. Also the real-time PCR to detect these 3 organisms. For viral isolates from the nasopharyngeal swab sample testing, we did the real-time RT-PCR to detect these 6 types of viruses. Here the etiological findings. From the blood culture of 464 samples, we isolate 18 samples, and here we can see that the gram-positive Bacillus and coagulase negative Staphylococcus and Micrococcus species, if we exclude this might be the probable contamination, then the overall percentage of the bacterial is 3%. And if we include them, the total is 40%, which might be unusual, as I here show a reference. Here is the resistance pattern where we can say that the penicillin G is the highest antibiotic which is resistant for several bacterium, and following by cotrimoxazole and erythromycin. The three potential major bacterium isolated from the blood by RT-PCR, where Streptococcus aureus is the highest number, 11%, following by Haemophilus influenza B, and only 4 Streptococcus pneumonia was found. And whenever we found the Streptococcus pneumonia from any type of sample like blood or nasopharyngeal swab, we did the serotyping, and these are the 4 types of serotypes we found from the blood sample. And we also try to show the single bacterial detection, double and multiple. So almost there is no difference in between them except for the double infection like Streptococcus aureus plus Streptococcus pneumoniae, which is slightly higher in the case group, like 11% than over the control group. So the serotypic distribution of the Streptococcus pneumoniae in case and control, if we consider the PCV10 vaccine coverage serotypes without 6EV, which is higher in the case group. Also, it should be noted that in the FDMN camps, they provided the PCV10 serotype vaccines. So then we showed the data PCV13, it is almost higher in the case group over the control groups. Here I showed the PCV10 serotypes. And a different graph which shows that some serotypes of Streptococcus pneumoniae is higher in cases, some are in control, like serotype 14, 15A, 10F, and 5, which is slightly higher in the case group over control group, which may be linked to the symptomatic cases. From the viral pathogen from nasopharyngeal swab testing, most of the viruses are higher in the case group under 5 years of age, like respiratory syncytial virus, hemophilia type A and B, human metapneumovirus, and adenoviruses. The graph is slightly changed. I don't know why. So now I like to talk about point of care testing among the FDMN population. We tested for 263 samples, both for blood and urine. From the blood, C-reactive protein was determined quantitatively, and from the urine, Streptococcus pneumoniae C polysaccharide antigen was tested. Here we can see the CRP value less than 5 among the 263 cases was 51%, and among this group, 43% were antibiotic given, and the greater value of CRP greater than 5 is 49%, and among them 71% were given antibiotic. The CN means non-interventional group was given the antibiotics through routine case management, and overall 70% participants were given antibiotics. So if we consider the whole data between intervention and non-intervention, we can clearly see that in the non-intervention, the antibiotic prescription is much higher than the intervention group, which is 70% and 57, 30, 43. Then we showed the disease progress and regression within 7 to 10 days, which is almost similar in all the groups, likely 95%, 98%, almost similar. And I would like to say no mortality case was found after within the 30 days, which is our last endpoint follow. So I would like to conclude PCV10 coverage without 6EV is higher, and these serotypes are also most prevalent in case over control. And 4 types of viruses are higher in cases under 5 age group, and point of care diagnostics can lead to more assertive cases management and treatment options in such a crisis settings. So in future, we may be more specified the serotypes groups like 18 group, whether it B or C, and 6 AB serogroups of Streptococcus pneumoniae to implement the PCV vaccine. We can do sequencing, whole genome sequencing to identify the resistance genes, to understand how to replicate this model in other crisis limit settings, and to develop and use more sensitive and specific techniques for pathogen identification. I would like to thank again Dr. Valentina and our only Dr. Faidusi Kadri, Dr. Navid Anjum Tanvir, and all our study staffs. Here are some pictures. Thank you, everyone.
Thank you, Abubakar, and we have only time for one question now. There is a quick question, otherwise we can So if there isn't anything, we can move on to the next speaker. Philippe.
No question? Okay. I would like to ask to Nabi Batum Tanvir to present his work on FTP COVID-19 SARS-CoV-2 detection and serological response cohort study in FDMN population in Cox's Bazar, a retrospective and prospective study. Please.
Good morning, everyone. I'm Dr. Navitanjum Tanvir from Bangladesh. I have been working in the Rohingya refugee camp since March 2018. And first of all, I would like to thank Dr. Valentina Pico and the Foundation Meru for inviting me to present our study in Gabriel Network meeting. Our study, excuse me.
Please, the slide.
So sorry for the inconvenience. Our study name is SARS-CoV-2 detection and serological response in the forcibly displaced Myanmar nationals in Cox's Bazar. And an infection with the SARS-CoV-2 coronavirus is an emerging infection that can lead to severe respiratory viral infection with a mortality of around 2 to 4%. The first case of COVID-19 was detected in the province of Wuhan in China on December 2019. About 250 million of confirmed COVID-19 cases are reported worldwide, including 5 million deaths. In August 2017, more than 0.7 million Rohingya population have fled into the coastal area of Cox's Bazar to protect themselves from the ethnic cleansing and took shelter in the humanitarian makeshift camps. At present, total number accounts about 1 million. And among the newly arrived Rohingya population, 60% are women and children. And they live in such a condition where public health intervention are lacking. And the refugee camps are densely populated with a poor health facilities, and including the lack access to water and poor sanitation and hygiene. The prevailing condition conferred with the high risk for COVID-19. After assessing the risk factors, IDC, with the support from the Dr. Valentina Pico, started the SARS-CoV-2 detection and serological response study in Cox's Bazar from March 2021 in 2 health facilities. The data from Cox's Bazar just after the influx shows that the highest mortality and morbidity rates are attributed from ARIs. You can see that morbidity rate is 36% in under 5 years of age group and 32% from all age group. And the death rates due to ARIs are 30% in under 5 years of age group and 36% for all age group. With the pandemic of COVID-19, the scenario has become more complicated. The first COVID-19 confirmed case among the FDMN was detected on 14th May 2020 from Ukhia Upazila. So far, more than 3,000 FDMNs have tested positive for COVID-19. You can see that in 2020, the number of confirmed COVID-19 cases among the FDMNs is very low. And we have started our study in the month of March 2021. After that, in the month of April, we observed an upsurge of COVID-19 confirmed cases, and which continues up to the month of August. Then after August, the trend is show a declining trend. Our study has 2 components. One is retrospective component, and another one is prospective recruitment component. Our sample size for retrospective part is 250 retrospective testing for SARS-CoV-2 from the samples which was collected in the lower respiratory tract infection study in the same catchment area from which was carried out from the July 2018 to March 2020. For prospective part, our target population is 100 confirmed COVID-19 cases with their household members, which number is approximately 500. We are collecting two types of sample from the cases and household. One is nasopharyngeal swabs and another one is whole blood. Objective of our study is to improve the understanding of the viral transmission and the epidemiological pattern of SARS-CoV-2 circulating in the Rohingya refugee camps prior to and during the outbreak period, and to evaluate the serological response to SARS-CoV-2 from identified COVID-19 cases and their household at point 0 and given endpoints of longitudinal intervals. Assess the risk factor that accentuate transmission, particularly in refugee camp settings. And our another motto is to improve the IPC measures in high crisis settings. We took the ethical approval from Bangladesh Medical Research Council, and our project duration is 18 months. We are now working in the Rohingya refugee camps, which was situated in the Ukhia Upazila, and we enrolled only the confirmed COVID-19 cases along with their household members. We started our study from 7th March 2021. Our partners are Foundation Meru, IDCR, Refugee Relief and Repatriation Commissioner Cox's Bazar, WHO, Food for Hungry, and Hope Field Hospital. This is our workflow. First, we identify the confirmed COVID-19 cases at healthcare unit. Then we take the consent, then complete the CRF. After that, we collect the NPS and whole blood. NPS will send for the RT-PCR, and blood are sent for the serological testing. For the primary cases, our study design, we have to take 4 samples from primary cases, and it has such as day 0, which day 1, which is identified as E0, that is endpoint 0, and we have to take another sample from 30 days of E0, which was identified as endpoint 1. And after 6 months of first enrollment, which is E0, we have to take another follow-up samples. After 12 months, we have to take another samples, which is identified as E0. So we have to collect 4 times sample from the cases. On the other hand, we have to collect the samples from household level in 2 different endpoints. One is E0, that is the day 1. After 30 days, we have to take the another follow-up samples from household members. We are conducting our study among the patients suffering from the severe acute respiratory infection or from this COVID-19 in 2 NGO-assisted SARI ITC in Cox's Bazar. One is Hope Field Hospital and another one is FH UNHCR SARI ITC. This is the picture of our 2 study sites. Total 14 SARI ITC are now active in camp level. Among them, 4 SARI ITCs have bed capacity of 40 isolation bed. We choose our 2 study site among these 4 sites. In each site, 2 of our study staff assigned to take the samples from the confirmed COVID-19 cases, and another team assigned to take samples from the household level. And we transport all the sample to Dhaka IDC laboratory for RT-PCR and serological test. Total 7 members are now working in the Cox's Bazar field level, including medical officer, nurse, medical technologist, and field assistant. And this is the picture of sample collection in the isolation center. And this is the sample collection in the household level. We have already done the our retrospective part. We have tested 250 samples, which are from the biobank of LARI project. And all the samples are negative for SARS-CoV-2. Till date, we have enrolled 193 confirmed COVID-19 cases and 152 household. In the first follow-up, we have completed 110 cases, including their household contacts. And for E2, we have completed 12 follow-ups till date. You can see the month-wise enrollment of our cases and household. You can see that in the May and June, the number of case enrollment is very high, but the number of household enrollment is low. This is because the strict lockdown by government of Bangladesh was going on in that period. So going to the household level, it was very difficult for us. This is the age distribution of our enrolled cases. 79% are adult, and on the other hand, household members, 65% are above 18 years of age. Among the cases, 52% are symptomatic and 48% are asymptomatic. We found only 3% cases are in cases that oxygen saturation are below 95%. Our cases suffered mostly from the fever, cough, sore throat, runny nose, headache, loss of sense of smell. This is the PCR data of primary cases. On E0, we have enrolled 193 confirmed cases, and which are all are RT-PCR positive. And after 30 days, we have completed 110 cases, took the first follow sample, and among these samples, only 5 became RT-PCR positive. This is the chart for household. On day 1, we have enrolled 152 household members. Among them, only 13 cases become positive for RT-PCR. And after 30 days, we have completed 80 follow-ups of household. And among these MPS, only 6 are become RT-PCR positive. This is the serological update. Among the 193 confirmed cases and 152 household members, we have completed the serology test of 185 cases and 137 households so far. So you can see that among the cases, 93% are IgG positive, and among the household members, 85% are IgG positive. So conclusion so far is that the exposure to COVID-19 wasn't present prior to the pandemic situation. We found lower number of household contacts who are COVID-19 positive at the time of testing in this study. This is maybe the cause that we have there is some delay of the enrollment of household. That's why due to lockdown, that's why maybe the RT-PCR result is low, but seropositivity is high. The seropositivity of cases and household contacts are both very high at the first time point of testing, suggesting exposure to COVID-19 is very high. Further testing will show if the level of antibody persists. Study is ongoing and follow-up is continuing to see the exposure and seroprevalence of the study cases and households. We face some challenges. The major challenges is the movement restriction, which results due to lockdown, which results the lower number of household members than expected. And this is very difficult to continue our study during the lockdown situation, but we tried our best to continue our study during the lockdown period, and we're trying hard not to miss any participant. And another challenge is language barrier. To overcome this situation, we hire the local community person to conduct our study in the field level. Vaccination in the FDMN camps have begun, and with it positivity, disease will hopefully decrease. This is another challenge because we have to check in our second follow-up and third follow-up the vaccination status. We will put the status in our case report form. COVID-19 response for a study, we already provided the IPC training to our study team, and we already provide all the personal protective equipments. If any of our study team faces any COVID-19 like symptoms, we immediately arrange the testing, and if they become positive, we ensure their isolation as well as their treatment. This is the picture of visit of our study team, including the Valentina Pico in the Rudolf Meru laboratory in Chittagong. I want to thank Dr. Valentina Pico for his tremendous support for this study. And I would also like to thank Dr. Kadriapa, our leader. I would also like to thank Abu Bakr for his tremendous lab work. And special thanks to our study staff and study participants. And thank you, Foundation Meru, for funding and support. Thank you.
Questions? Oui, Mark. Yes, Mark.
Yeah, I can hear you.
cases?
Actually, most of I didn't show here because the age distribution is we enroll more of the cases are above 18 years of age.
Yes,
And-
but above 80 years of age, they were older. You don't have an idea of.
And the percentage is near
No?
about 70 to 80%. But I did not extract here for this presentation. But probably it will be 70 to 80%.
And owing to the very high percentage of seropositive household
Yeah.
contact,
Yeah.
do you have any idea of the percentage of contact who developed symptom or not?
Actually, we are supposed to take the household samples just after 1 or 2 days of enrollment of cases. So, but due to lockdown, we have the duration is much higher. Sometimes we are delayed to take the samples up to 7 or 10 days. That's why maybe the RT-PCR result became negative, but IgG was positive. This
But-
may be the
yeah.
delaying of the sample collection of household. This may be the cause.
But you didn't have any questionnaire to know whether the household contact developed or not symptom at one time.
Yeah.
Point. No,
Sorry, I couldn't.
sorry.
The question is whether we have a CRF for the household contacts.
Yeah,
And
we
yes,
ha-
we did.
yeah,
We
we
did
did.
have. So we know whether who from those contacts, household contacts were asymptomatic and who developed symptoms. We didn't show the data, but we have this data. We have a CRF for them.
Because this would be interesting to compare this with the results that Bill obtained in Haiti and see whether most of these did not actually develop symptom or whether they developed it. Also, just so perhaps I missed this, but when you perform your retrospective analysis of samples before the pandemic, so this was only by PCR, or did you check with your serological assays that this serological testing was negative?
We perform only PCR.
Ah, okay. So you don't know whether actually the sample were really negative for serological testing.
Actually, we choose the sample in the last 6 months of our enrollment in LARI project, which was just prior to the pandemic started.
Yeah.
In last 6 months of enrollment of LARI project.
Yeah. Well, this can be key when you have 85% of household contact. Yeah.
So can I add, Mark? For Bangladesh, even in March, there was no. I've done PCR. He's done, and we've done a lot of work on serology.
Yeah.
We've looked at different divisions of Bangladesh, in north, south. There was no antibody, nothing
Okay.
at all.
With the
And-
same kits.
yeah, but
Okay.
then as soon as we approached the pandemic and went on, the seroprevalence kept rising. So another study has been done by WHO where using a kit, the one-time kit, and they were amazed even 8 months or 9 months ago to find like 60%, 70% seroprevalence.
Mm.
And we are doing it in other places of Chittagong division, which this place is also in the Chittagong division. It's almost 70%.
Okay.
So if there's infection, which we will not know, either they had it before the index case or after it, or because of the problem due to, it's very difficult to approach the camps.
Mm.
I mean, we have to have special permissions. I mean, what Navid said and Valentina is directing, it's a very difficult situation in the camps. It's actually refugee camps. We call them the FDM camp. So accessing the camp is difficult. During lockdowns, you're not allowed to go in. So
But your feeling would be that the seroprevalence is higher or equivalent in camps versus outside the camps?
I would think maybe it can be higher because they're so clustered together.
Yeah.
There's more people living together in the camps. In our urban slums in April 2020, there was 70%, 75% seroprevalence, whereas the national average was 45%. The exposure rate is very high, but they're not all sick.
Yes.
Were you able to associate the household transmission with any particular variants? And the second question is, has there been any effort, and this question also will go for the other speakers, to evaluate the risk of tuberculosis? Because this is exactly the same type of mechanism that you go through. And those refugee centers are high site for TB, because in our experience, when we did it, we found a lot of cases of tuberculosis.
Actually, we don't perform any variant sequencing right now. This is maybe our for our future plan. Maybe we can add this in our future activities. And can you repeat the second question?
On TB,
if TB. Oh, actually, we didn't identify any TB cases because it's not our part of a study, but it will be better if we include in future.
In urban slums, we did another study. Dr. Jannat is part of it, and we found latent TB to be in the controls, not the pay, to be as high as 11%.
Yeah, actually, the reason why I ask is because it could change completely your mortality rate. We found people who had both COVID and TB. And obviously, if you're treating COVID and you're treating TB, you're going to have a lot of patients die.
Thank you very much. Thank you. So we move to the next presentation. Florence, maybe by online. Okay. And after we will have more time for questions.
After this presentation, there will be some time for discussion.
Then Liz Grant-Slade is connected.
Hi, everyone.
Hi. Happy to see you. It works very well. Thank you very much. So Liz Grant-Slade is co-founder and coordinator of the Every Breath Count Coalition. She's involved with many projects with a non-governmental association, but also with policymakers. And then you will present the Every Breath Counts Coalition, please.
Thank you very much. So very pleased to be with you at the 11th Gabriel Network meeting. And thank you to the Merio Foundation for hosting us. So my presentation today is drawn from new analysis that the Every Breath Counts Coalition published in October 2021. And the report, which you can see on the screen, was called The Missing Piece: Why the Global Pandemic is an Inflection Point for Pneumonia Control. And it uses the latest global burden of disease data from 2019, together with official WHO reported COVID-19 deaths, which we know are an undercount, perhaps by as much as 5 times. So putting together those two data sets to give us an image, a picture of just how massive the burden of respiratory infection is now, together with COVID-19. I want to just start with an image. Everybody has an image from the pandemic, I think, that haunts them, that motivates them to do more. This is that image for me. This was taken in February in Peru, which was deep in an oxygen crisis caused by COVID-19. This is a person, we don't know man or woman, but they're sleeping overnight, waiting in line for their oxygen. The oxygen is most likely to be taken home for a sick loved one, because the hospitals were full and people were taking care of their family members at home, and all they had was oxygen. This story replayed itself in many, many parts of the global south. It swept through Asia, through Africa, the Middle East, and it continues to this day. So my question for us is, how did we get here? How was the world so blindsided by a pandemic of respiratory infection? I want to take you back to before the pandemic, to 2019, which is where this data comes from. This is Global Burden of Disease 2019 data. And you can see here, even before COVID, pneumonia or respiratory infection, that's the yellow bar, was the leading infectious cause of death in the world. So it's lined up here, it comes after heart disease, stroke, and COPD as the fourth killer across all ages. Now we can add in there COVID deaths, and you're adding a burden of 2 million. It's risen now in 2021. So COVID has added to what was already a massive burden of respiratory infection. Now, contrast that with some of the other leading infectious killers. Diarrhea is number 2, 1.5 million. And then you see the others that we talk a lot more about, particularly HIV, AIDS, TB, and malaria. We have massive efforts underway to control those diseases. But you can see what we're heading into when you put the COVID deaths together with the non-COVID pneumonia. By far and away, this has become, respiratory infections, the leading cause of infectious disease death in the world. We know that pneumonia is a little bit different to some of the other infectious disease killers in that it infects the very young and the very old disproportionately. So you have a U-shaped curve across the life cycle. Some of the other diseases don't look like this. HIV and TB disproportionately impact adults. So you have an inverted U, it's the opposite of this. And malaria targets children more than the older adults. So you have an L-shaped curve if you plot it. So pneumonia is quite distinct in that it targets the very young and the very old. Now, COVID has hit older adults, but there's nothing to say future respiratory pandemics could emerge that target children. We hope that never happens, but it is a high risk. Children, let's talk a little bit about them. We know that pneumonia is the leading cause of death for children. Preterm birth is very, very close, but it's pneumonia. And this has been the case for as long as I've been working in global health, and that's 3 decades. So it's always been a leading killer of children under 5. When we look at the risk factors, the other beauty, I think, of using GBD data is you don't just get the cause of death, but the risk factors that contribute to that burden of death. And when it comes to respiratory infection, it is air pollution, no question, that is now the leading risk factor for pneumonia death for all ages. We've split it here by household and outdoor. So if you put them together, it's even a lot, you can see it's even more impactful. The reason that's so important is we're in the middle of a climate crisis. And as we speak today, the parties are meeting in Glasgow at COP26, where they're discussing air pollution. And air pollution is rising in many of our cities and rural areas across the world because of the burning of fossil fuels. So this is a risk factor, unlike many of the others, that is not declining. Many of these other risk factors like hand washing and even child wasting, we have big efforts underway that are making inroads into reducing those risk factors. But air pollution is something that is going to continue to rise if we don't get the climate crisis under control. And that will continue to put pressure on deaths from respiratory infections. We know that deaths, now this is pre-COVID, all this data I'm presenting is GBD 2019, so it's pre-COVID. We know that deaths from respiratory infection are very concentrated in the world. Here you see 3 regions, Sub-Saharan Africa, number 1, South Asia and East Asia, Pacific on a par, but look at the different age profile. The green bars are the children, and you can see the burden of pneumonia carried by children in Sub-Saharan Africa and South Asia. But as we move into East Asia, you can see it shifting to our older adults. So it's generally true as countries develop, the pneumonia burden shifts to older age groups, but we have many middle-income countries that have a double burden of pneumonia amongst both children and older adults, and you can see them here. This is a deep dive into the 20 countries, 20, with the largest numbers of pneumonia deaths across all ages. Once again, look at the age breakdown. I think this chart is very, very important. Look at India, burdens across all age categories. But when you go to Nigeria, you can see children dominate. This information has huge implications for how a government approaches, policies and programs to reduce pneumonia. Some governments are going to have to be active with all populations. Some can zero in on children, but very important that these countries know where their pneumonia burden lies across age populations. COVID is going to shift this story, of course, because COVID has disproportionately impacted adults. We'll get to that shortly. Unlike other leading infectious killers, pneumonia deaths are not declining at the same level as other killers. You can see here between 2000 and 2019, pneumonia deaths have fallen by just 14% compared to much more significant reductions in the other leading killers. Now, to be fair, we do have the Global Fund for AIDS, TB and malaria. We do have PEPFAR and PMI, two flagship initiatives of the US government, which have been funding major efforts to reduce deaths from HIV, AIDS, TB and malaria. We don't have anything equivalent in pneumonia, and we never have. And you can see the impact of the neglect of pneumonia with that slower rate of reduction. Now, some of that is driven by aging of populations, but a lot of it is driven by simple inaction. So what has the global health community been doing? Not enough, but to the extent that they have been trying to help governments reduce their burden of respiratory infection, it's pretty much all been vaccine. And you can see here, and through Gavi, the Vaccine Alliance, you can see here the pneumococcal conjugate vaccine, a very expensive vaccine. It's only just coming down in price, and the Hib vaccine. This picture here really tells you the large extent of what the global health community has been doing to fight pneumonia. It's been focused on funding 2 vaccines for children under 5. Very important, but completely inadequate to the burden of pneumonia across the life course and to the risk factors that we need to be active on. And I should say, even with all of this investment, we still have more than 50% of children in the world who don't get the pneumococcal conjugate vaccine. This is one of the most powerful vaccines that the majority of children do not get. So we even have a lot further to go with increasing coverage of pneumonia vaccines amongst children. Overall, global development assistance for pneumonia, and we all know this, it's much less than it is for malaria and AIDS, for example. You can see it here in the picture, the tiny yellow sliver on the top. It's less than 5% of development assistance for infectious diseases. It's never really risen above that. And when you contrast that with the burden, about 32% of infectious disease deaths are the result of respiratory infection. Once again, this is before we add in COVID deaths. So you can see why we were so vulnerable to a pandemic of respiratory infection when this was the kind of level of our investment prior to 2020. This is global support from the global health community. I'm talking about USA, the government donors, USA, the UK, the Europeans, the Japanese, the group of governments that prop up global health. It also includes private foundations like the Bill and Melinda Gates Foundation, who have played an outsized role in financing pneumonia for sure. And most of this funding flows through multilaterals like Gavi, the Global Fund, and the UN agencies, WHO and UNICEF. If you look at national governments, what are they doing to fight pneumonia? You'll see a similar picture. So you can turn to any government in Africa or Asia or Latin America, you will struggle to see on the books of the Ministry of Health a pneumonia control program. It just doesn't exist. There'll be line items for HIV, AIDS, there'll be malaria, there'll be tuberculosis programs, but it's hard to find an established, well-resourced respiratory infection program, once again, prior to COVID-19. So let's pivot now a little bit before I conclude to what has happened since that picture I just painted. As COVID hit countries one after one and the cases started rising, what we saw was the complete inability of health systems to treat patients with respiratory infection. And that came down to lack of tools like pulse oximeters and a massive lack of oxygen, medical oxygen. And we've all seen the images over the last 2 years of hospitals scrambling for oxygen. We built a COVID-19 oxygen needs tracker, and the data here is from that tracker. We launched it about this time last year for World Pneumonia Day, and it measures the daily need for medical oxygen to treat COVID patients in low and middle income countries. This is all of them together, tracking since October 2020. That big wave you see in April, May is India and Nepal, when we all watched desperately the tragic images of families and hospitals, doctors, nurses in India scramble to find oxygen, often unsuccessfully. And there are a lot of excess deaths in India because of lack of access to oxygen. It's settled down a bit now, but we still have many countries in crisis or at risk of an oxygen crisis. This is another piece of data we produce every week and have been doing so for many months now. It just highlights for the global health community the countries where their oxygen need is very worrying in terms of shortages and deaths. We color code these countries. Red means it's a code red crisis. These countries, if they don't get support, hospitals will run out of oxygen, there will be elevated deaths. Yellow countries have a very high but stable oxygen need. They've had some time to adjust to the rapid surge. And the green countries are coming down off a very high surge. So once again, the pressure is off, at least in the short term. I'll just let you spend a little. This is a very important picture, and we've been drawing the UN's attention to this picture and all the different groups that are financing oxygen. This is where we ask them to target their support to prevent a repeat of the India-Nepal scenario. We hope we never have to see that again. Once again, it's a reflection of decades of underinvestment in respiratory infections, care, diagnosis and care in hospitals all across the global south. So now what's happening is that many low and middle income countries are left now with double burdens of pneumonia. This is the language we're using, double burdens from COVID-19 and from non-COVID-19 causes of pneumonia. And this graph just shows some of the countries with the worst double burdens. So they entered the pandemic with massive burdens of respiratory infection deaths, and they've added to those with COVID deaths. So their health systems, as you can imagine, the underlying need didn't go away. It's still there. The blue bar is still there. All the people that need diagnosis and treatment from non-COVID causes. And then you add into that the emergency needs of COVID patients. It's no surprise health systems all across the global south are under the most extreme pressure and are not able to function effectively. And yet, here's another picture we find as having a lot of impact. As bad as this COVID wave is of patients, it is the tip of the iceberg. This underlying unmet need for oxygen has always been there. And we know the need for oxygen ranges from the tiniest newborn through to children with pneumonia, women in childbirth, older patients with both infectious and non-infectious conditions. Let's not forget COPD and the chronic needs of respiratory care patients that are non-infectious. They all need oxygen and health systems that can provide a proper respiratory care. And currently that's what we're not providing. So COVID has almost exposed a problem that's always been there, and it's a big wake-up call for the world. So what needs to be done? These are my final two slides. We have very specific recommendations for governments and global health actors and for the research community as well. So we expect coming out of the pandemic, every government to have what we're calling a pneumonia control strategy. These used to exist way back in the day when WHO had a decent ARI program. This is the language they used, but it ended, it stopped. We dropped the ball on this somewhere in the early 90s. We need to bring national pneumonia control strategies back. They need to be linked to pandemic preparedness and response. We need the World Health Assembly to endorse this approach. And we need annual national pneumonia mortality reduction and intervention coverage targets. Governments do not measure this. They do not measure progress to pneumonia mortality reduction targets. So if they're not measuring it, they're not focused on it. Support, we expect governments to spend more domestic financing on pneumonia control as part of universal health coverage. We don't want pneumonia to be left once again off the list of infectious diseases that governments will finance through UHC. And we want to see official development assistance, that's global health financing, at least 10%, it's currently 5%. We want to see it at least double coming out of the pandemic. And that means Gavi, the World Bank, the Global Fund will all need to remain active, which they're currently doing that in the pandemic. They're all active in this space. We want that to continue. Innovation, currently 3%, and you will know this is your community. 3% of infectious disease research funding prior to the pandemic was allocated to respiratory infection. Appalling. We want to see that go to 20% at least. That's not even commensurate with its burden, but it's closer. We want to sit down with the infectious disease donors, there aren't that many of them, and ask them to focus and increase in this area. We want to see prioritized investment in breakthrough technologies. There's some exciting things happening in respiratory infection diagnosis and treatment and risk reduction and vaccination. We have an RSV vaccine coming, and there are more vaccines, particularly targeting the viral causes of pneumonia that are in the pipeline. We want this whole innovation area accelerated. We want to see partnerships. The pneumonia community has struggled as a small group, relatively on the sidelines of global health for too long. We want to see partnerships and networks at global, regional and national levels. So we're all working much more closely together, including with the pandemic preparedness and response agenda. And we want to see more champions. So we're calling for bilateral pneumonia summits. We held one in Barcelona in January 2020. Some of you may have been there, a hugely successful global pneumonia summit. We want more regular convenings like that, which are broad. So not just the research community, let's bring everyone together, advocates, researchers, activists, all together under the one umbrella to continue to put pressure on governments and global health agencies to stay on task with pneumonia control. And we want to highlight best practices. There are countries that are doing very, very good work, including in pandemic control. And we want to always have those high-performing countries front and center. So let me leave you with a question, which is an alarming question, but I think we all have to have our hearts and minds focused on it. Have we in fact entered an era of pandemics, respiratory infection pandemics? Is this going to be the first of several, where factors like climate change, urbanization, air pollution, increased mobility, increased chronic conditions and aging populations, all of these things will align in a kind of toxic relationship to increase the risk of respiratory pandemics and pneumonia deaths? If that's the case, are we prepared? Our analysis suggests we are not, and we all have to make some very big changes to prioritize this area of infectious disease so we never again have to experience the horror of what we have been through over the last 2 years and many countries continue to endure. Thank you very much.
Thank you very much for this presentation. Any question or comment on this presentation? Yes, please, Valentina.
Well, I just have a comment. I'd like to thank a lot Leith for accepting our invitation to come over. I think that's really important to showcase the landscape and arena and where the respiratory infectious diseases are moving today. And actually the push of COVID towards this agenda that is now, I remember we met in the Barcelona Forum in 2019, how hard it's been to put people together again. I just would like to let you know that we have a global forum on pneumonia that we will be organizing, Merius Foundation, and we will be talking about it in the next, coming months. So,
oh, wonderful! That's fantastic.
Exactly. We start awareness, continue the awareness on pneumonia, and I think we all work towards this agenda. So, thank you so much for being with us today.
Thank you, my pleasure. Thank you for the invitation. I'd like also to extend an invitation to all of the researchers there. You know, when we would love to, we're going to approach research funders shortly. We're about to publish a list of pneumonia research priorities to 2030. So we've surveyed, many of you may have been surveyed in this exercise. We've surveyed a lot of global pneumonia researchers to come up with an agreed list of 20 research priorities for the next decade. We're publishing that, and then we're going to take that to donors, research donors, and say you need to be investing in this research. So we would love your partnership with that, and I can share more information about that if it's helpful.
It will be definitely helpful, and we will help you to disseminate that.
Thank you.
Hi. It was extremely interesting to listen to your, yeah. Huh? Okay, thank you so much. And I have a personal experience with pneumonia. Last 2 months ago, I lost my husband to pneumonia, community-acquired pneumonia and antimicrobial resistance, one led to another. And I can feel that what you said is right. Attention is not being given to pneumonia. It's something that is vaccine-driven. I mean, when we talk about pneumonia, we are just putting the vaccines in front and the vaccines don't work. He was given the best vaccine for pneumonia, and it didn't work 2 years ago with a life of 5 years vaccine. So I think that it's a really big cause, and non-COVID pneumonia, because we are so concerned now about COVID pneumonia, but there's so many non-COVID pneumonias out there, people dying. So I think it's a case that must have a champion, and it's not there. And we talk about low acute respiratory infection, under 5s, over 70s, but enough attention is not given. There are no partners, no developmental partners who are giving that. Everything is vaccine driven. So I think I really enjoyed your talk, and I cannot tell you what it meant to me. Thank you.
Thank you very much. And I'm so sorry for your loss. There are so many personal stories like that. We hear them all the time. So part of what motivates us in our coalition, the Every Breath Counts Coalition, is to be a voice for people like you and who have stories like that, where the system just let them down and there's been a death that could have been prevented.
Thank you. Wait, please.
A very nice presentation, very interesting picture of the real situation. Yes, I'm from South America, and I just wanted to say that yes, this pandemic showed to developing countries that the investment in public health infrastructure was really, really bad for decades. So, but also the pandemic hit very nice public health systems working, like in Europe, for example, yes. So, but for us, for developing countries, we learn a lot. And I think that this is a big, strong opportunity for pneumonia as a respiratory disease to just to see a positive thing, yes? That some infrastructure has been implemented through the pandemic. There are better diagnostic systems in many places around our countries, even for rural areas that we didn't have before. So let's think in a positive way that this is the political time situation to make a strong commitment and a strong project, future projects working with all this infrastructure that has been implemented in most of developing countries that we didn't have for decades. Thank you.
I love that message of opportunity. I think that's exactly right. Let me tell you a quick story. So prior to the pandemic, we would sit down with the Global Fund regularly and say to the Global Fund for HIV, AIDS, TB, and malaria, you need to pay attention to pneumonia and respiratory infection. And we were always told, no, we have a very strict mandate. We cannot move beyond those 3 diseases. And we said, oh, okay, we kept trying though. Now, during the pandemic, the Global Fund has played a huge role in helping low and middle income countries buy respiratory care equipment, pulse oximeters, oxygen, ventilators, patient monitors, you name it. In fact, the Global Fund has spent $500 million helping low and middle income countries get oxygen supplies, something they said they would never do. So what has happened during the pandemic is a lot of the rigid barriers that existed in global health, where one agency simply wouldn't do certain things, have disappeared. And it's been all hands on deck. We've all had to come together and just work out ways to help low and middle income country governments. I hope we don't lose that flexibility and go back to the way it was. I hope we're going to have a big conversation very soon about how we not only rebuild health systems in low and middle income countries, you said that work is happening and it is, but also rebuild the global health architecture. So it's fit for the modern era where we don't really know where the next pandemic will come from, but we know it has a high risk of being respiratory related because it's the transmission. When you have something that's transmitted by the human activities of breathing and talking and singing and laughing, you know, that's where you have something highly transmissible. So we have to get our health systems in order to deal with respiratory infections, or we're going to have this happen again in a few years, and there'll be no excuse for that if that happens. That would be completely unacceptable.
Thank you. Comment, question? Thank you very much. So we have time for other questions regarding previous presentation. If you have some comment or question, please, Florence.
Yes, I have a question for the previous speakers concerning the Nosocore project. So it's a question for Mitra, sorry, Mandant and Dauda. According to the result that you have obtained so far, do you implement new preventions and control measures at the level of hospitals to stop the nosocomial transmission of COVID-19? What can be proposed, or do you have some new guidelines according to the result that you have obtained so far?
I think Philippe is a better person for hygiene in hospital, but yes, we have new guidelines, of course, according to the government, French government, and also in the hospital, but probably Philippe can give you more details about this new guidelines.
Yes, but maybe I can give the response for my colleagues from Côte d'Ivoire and Madagascar if they would like to answer before.
Yes, thank you for your question, Florence. For Madagascar, as I have presented in the slides, we will communicate the results at the end of the study when we will have the result of the analysis of data. And of course, there will be a discussion with the clinicians in the hospitals in order to find how are we going, what things will we apply to fight against the nosocomial transmission. And I think with Professor Philippe, there is more information about the guidelines. Thank you.
Okay. Yes, please.
Okay, merci. Pour la Côte d'Ivoire, nous sommes engagés dans un processus de mettre en place un programme de contrôle de l'infection en milieu hospitalier. Donc, sur la base de ces informations qui montrent le risque pour le personnel de santé, le programme est en train d'être déployé. Et donc, il inclut une formation et la mise en place de mesures au niveau de ces structures-là. Merci.
Maybe I can give you some additional comment from, for example, for Lyon University Hospital, the precaution are mostly focused on droplet transmission and also on the antigen. So it's not so fantastic measure. It's a very classical proposition regarding the control of the transmission. But it was difficult to apply in every unit, every ward, every hospital, because healthcare workers are tired. There is a very high level of workload. There is some difficulties with visitors who apply or not the use or not the mask, and also for even for the patient in some ward, like a psychiatric unit where a patient they are the ambulated patient, or they go everywhere, and it's very difficult to control, for example. So it was not difficult in terms of technicity. It was difficult regarding the capacity to apply relatively simple measure. And now, of course, with the vaccine for the healthcare workers and for high-risk patients, probably the risk of transmission during the hospitalization will be will decrease, but we face every week or regularly some cluster of cases in the unit. So there is no revolutionary guidelines that must to be applied. It is more the healthcare workers are tired. This is a long outbreak. This is now pandemic.
But did you see the same with the flu? Because I know that you have done a lot of works concerning the nosocomial transmission of flu. Is it similar or?
But the seasonal flu is relatively short. So we can organize in autumn, for example, campaign of communication and prevention, and there is a seasonal flu, maybe 2 months or 3 months, and after it's finished, and then we go to the next one. But for this pandemic with a wave, unexpected wave, a natural history, a little bit strange, so it's difficult to maintain the level of prevention during all the period of pandemic, and there is some high and low period of adherence to the guidelines. It's why it's difficult. Yes.
I don't know if the studies are powered enough to look at it, but have you been able to see a decreased mortality as the medical staff became more familiar with handling those cases, particularly by not using respirators as much as they did earlier?
Look, your question is a decrease of mortality rate across time since the beginning of the outbreak of the epidemic. Yes, of course, because new result from clinical trial, for example, with using a steroid or treatment against thromboembolic complications, and then the rate of the mortality rate decrease, and even if very old patient. And yes. Yes, Jean-Luc?
Also a question for the Nosocor staff. Do you have any data about the impact of vaccination of the medical staff on the number of cases of hospital-acquired COVID?
Maybe somebody would like to answer. Not yet. Not yet. You know that the vaccination for healthcare workers is mandatory in France now, but it was not the case at the beginning of the epidemic. And the question is like for flu, but it's the concept is similar, but the results are different. That can we obtain some level of vaccine coverage in healthcare worker with an impact of protection of patients? And then this is now it's one of the probably future project, but not only in Lyon, in many countries, to try to correlate or to study the link between the level of protection of healthcare workers by vaccine to the risk of nosocomial COVID among patients. Even a patient at risk are also vaccinated, then the risk of the circulation of the virus in the hospital will decrease also because of the vaccination of patients and completed by vaccination of healthcare workers. So in my institution, we have not yet the result of these two correlations, but maybe some colleagues can add additional
Just like to say
comment.
that the variable is collected. I also call it Munalis in Madagascar. Madranto, maybe you want to add, we are including this variable of vaccination because the vaccination started also not long ago. So that's something that it needs to be correlated prospectively now for many sites.
Also, just to add, we are doing studies in Bangladesh on people who are vaccinated and coming to the hospitals and looking at their outcome. It's a test negative design. It's mostly on patients that are coming to the triages, and whether they've been vaccinated or not, it's sort of, yeah. But then generally it's believed there's some studies, not clinical trials like we are doing, but they're saying that people who are dying are the ones who are not vaccinated. There are many patients coming to the hospitals in Bangladesh, but the ones who have the fatality rate, the fatality is not among those who have been vaccinated. But this is not a controlled study, it's just the presumption.
Thank you. Other question or comment? Well, even Florence, we're on time. But,
yes, thank you very much for all the speakers, for the two chairmen, and we are perfectly on time. So now we will have a break for the lunch, and we will come back at 2 p.m. for the next session on AMR. Thank you.
Thank you very much.